This is Outbreak News This Week, brought to you by the Global Dispatch Incorporated. Outbreak News This Week is your source for all the news about worms and germs. And now, your host, microbiologist and editor of OutbreakNewsToday.com. Here's Robert Harriman.
Well, good evening, Tampa Bay. This is Robert, and I appreciate you listening to the place for all your news about worms and germs. And I encourage you to check out the website. That's OutbreakNewsToday.com, OutbreakNewsToday.com. Follow on social media. Facebook is Infectious Disease News, and on Twitter, at BacTman63. And as many of you know, I launched a podcast about 2 months ago. It's doing quite well. And I encourage you to check that out on iTunes and Stitcher Radio, whatever your favorite platform is. And some of the more recent ones I did in the past week or so, I spoke to parasitologist Rosemary Drisdell about amoebiasis. So you might find that interesting. I spoke to an expert out of George Mason University asking the question, what do we actually know about North Korea's bioweapon program? And just the other day, I spoke to Dr. Mike Osterholm up at CIDRAP and about what's happening with Zika. And I'm going to play a little segment of that probably in the second half. And I'm very encouraged that we will be doing something on a regular basis, kind of the story behind the story. So I appreciate Dr. Osterholm for lending his time for that. Let's just try to take a look at a little bit of infectious disease news out of the state of Florida before my guest comes on. And Cyclospora is a parasite. And the CDC is reporting 712 laboratory-confirmed cases nationwide this year. And about half of those are contracted right here in this country. And what you probably didn't know is, only Texas has seen more cases. Florida is number 2. And that caught me by surprise, too, because I really haven't heard a lot about that on any kind of local media here. So, yeah, Cyclospora is being seen in the state of Florida right now. And this outbreak that's going on in the country, Cyclospora is always a difficult investigation. So they're still working on it. They have not been able to point out a specific source, a specific vehicle, and it continues. But historically, we have seen many times it's been related to imported fresh produce like cilantro and raspberries. So we'll be keeping an eye on that. Okay. My first guest today is going to be Stephen LaRosa, MD, and we're going to discuss several topics in general infectious diseases. Dr. LaRosa is an infectious disease physician. He's based out of Beverly, Massachusetts. Dr. LaRosa, welcome to the show, sir.
Hi, good evening. Thanks for having me.
Glad to have you. Now, I thoroughly enjoyed reading your blog. It's entitled My Thoughts on the Future of Infectious Disease in Medicine. And if you're interested in it, you can check it out online at drlarosa.blogspot.com. And there's a few articles I really wanted to look at with a little more detail here on the show today. And the post that intrigued me the most was what you called my favorite infectious disease teaching points, or you call it your pearls. And you list 21 pearls. And they're concerning treatments, they're concerning diagnostics, and the information that you're teaching medical students. And I'd like to have you elaborate on some of them. So the first one I'd like to have you talk about is, you write, for patients with pneumonia, order a MRSA screen on the nares and throat. If these are both negative, you do not have a sputum culture with MRSA, so you can stop the vancomycin. Can you talk more about that?
Yeah, sure. I mean, by and large, vancomycin, which is used against MRSA infections, is overused, and it's usually included as an empiric component of treatment for hospital-acquired pneumonia and healthcare-associated pneumonia. Yet, there's good data from a few studies now that if you don't have a sputum that grows MRSA, and oftentimes you won't even have a sputum culture in cases of pneumonia, that if somebody does not have MRSA from a culture of their nose or throat, you're actually able to safely stop the vancomycin and not include it as part of the empiric treatment of pneumonia. So it's really become a key component of stewardship to try to save vancomycin for when you really need it and not give it excessively.
Yeah, and that's really something that you focus on your blog, is antibiotic stewardship. And another pearl that you mentioned in the blog is, I do not use vancomycin for MRSA infections where the vancomycin MIC is 2 or greater. Can you first explain to the audience what an MIC is, and then explain your thinking behind this?
Sure. So an MIC, or mean inhibitory concentration, is the amount of an antibiotic that you need to kill a given bacteria. And it's an in vitro test. It's done in the lab. It's done on a plate or in a test tube. And so what it is, it's the concentration. And for vancomycin, what's critical in killing the bacteria is both the concentration of the vancomycin as well as the amount of time that the concentration is above the MIC, the amount to kill the organism. And for vancomycin, the key parameter is having an area under the curve concentration over the MIC. So basically, go back to your division days, AUC over MIC greater than 400. That's what your target goal is. Well, as that MIC rises, and that's the denominator again, as it goes from 1 to 2, the concentration and the dose of vancomycin that you need increases dramatically. And when you get to an MIC of 2 or greater, you often will need greater than 3 or 4 grams of vancomycin a day to achieve that. And sometimes it takes, in a young, healthy person, 6 grams, 7 grams. And we know that once you get over 3 grams a day, the risk of kidney injury, nephrotoxicity, goes up dramatically. So, one, it's hard to hit the target of an AUC to MIC of more than 400 when the MIC is 2 with vancomycin, and it's really hard to do that without incurring some nephrotoxicity. So in those settings where the lab report comes back that you have an organism with an MIC of 2 or greater, I go to an alternative agent such as daptomycin or ceftaroline or an alternative agent. So it's just it's the key parameter. People often will, and even in guidelines, will tell you to check vancomycin troughs, but those aren't as reliable as calculating an AUC to MIC.
Okay, very good. Now, vancomycin, you write, is inferior to beta-lactam drugs for the treatment of serious methicillin susceptible Staph aureus infections. First, what is a beta-lactam drug, and can you elaborate on that pearl?
Sure. So the beta-lactam is part of the chemical construct, the structure of an antibiotic, and the classes. Typical beta-lactam drugs are the penicillins and the cephalosporins. And for an organism that's a so-called methicillin-sensitive Staph aureus or oxacillin-sensitive Staph aureus, there's now a number of studies in critical illness that using a beta-lactam such as nafcillin or oxacillin or cefazolin, the outcomes are much better than if you use vancomycin. And this will probably get into something that we'll talk about is that, people are inappropriately ascribed a penicillin allergy, and they're given vancomycin, and that's not for an MSSA infection, and that's not without some potential complications. So The point being is if the infection is MSSA, you're always based on data better off giving a beta-lactam drug than vancomycin.
Right, and you say there's potential complications. You've already mentioned the toxicity of vancomycin. What other complications are we talking about?
From the vancomycin itself?
Yeah.
Or, so nephrotoxicity, bone marrow suppression from vancomycin, and just the outcomes being poorer with a methicillin-sensitive infection based on numerous well-done studies. Mm-hmm. So, and it's really in the patient's best interest for them to get a beta-lactam agent in this setting.
And cost is an issue too, isn't it? I mean, vancomycin is not cheap.
It's a lot cheaper now, actually, that it's really off patent. It's
okay.
Usually it's not and in fact, to get back to the previous point about the AUC to MIC, you often have to make a serious claim of when you want to use an alternative drug to vancomycin, because vancomycin is a lot cheaper than a lot of the alternatives. But I think there's good basis that when the MIC is high that you shouldn't use it.
I can remember years ago I read an article and it was saying that vancomycin is more expensive than gold per ounce. I don't know how true that was, but
yeah. Well, unfortunately, it's relatively cheap compared to some of the newer anti-staphylococcal agents that are out there.
Another pearl you write is, if Staph aureus grows in a blood culture within 14 hours of the time it's collected, then an endovascular infection is likely. What do you mean by endovascular infection, and elaborate on that point?
Sure. So when I refer to an endovascular infection, I refer to infection that is within a blood vessel, a vein or artery, or another cardiovascular structure such as a heart valve. So everyone understands. So when the blood cultures are collected, they're usually collected into two tubes, an aerobic and anaerobic bottle. But the technique, they're put into an automatic reader, which reads the bottles continuously to detect bacterial growth within the blood culture system. So you actually get an exact time where you know the blood culture has been collected, but you get an exact time of when the machine that reads the blood cultures triggers that it's a positive result. And the time that it takes between it's collected and it's positive is called the time to positivity. And that's an exact number that you can get from the lab. And it's a very good surrogate marker for how many organisms are actually present in the blood. So it tells you really about burden of the bacteremia.
Sure.
So it stands to when you have a large number of organisms in the blood culture will grow a lot faster. The time to positivity from the lab will be short. And there's good data that when it's less than 14 hours in the setting of Staph aureus, that what it should tell the clinician is that there is an infection either within a blood vessel or on a heart valve. So it should trigger either ultrasounds in the case of blood vessels or cardiac echoes to be looking for endocarditis.
Oh, very interesting. All right, let's get a word from our sponsor. For many years, we have been waiting for a Lyme disease test that actually works. After decades of research by Dr. Richard Marconi, a professor at the Medical Center at Virginia Commonwealth University, a breakthrough test has been developed. The GLD test, recently launched by Global Lyme Diagnostics, is based on Dr. Marconi's science. For more information, visit glymedx.com. That's glymedx.com, or email them at info@glymedx.com. I'm talking to infectious disease physician, Dr. Stephen LaRosa, and we're just going over a variety of different topics in infectious diseases. And in the topics that I'm going over is out of his blog. It's called My Thoughts on the Future of Infectious Disease in Medicine. And that can be found at Dr. LaRosa, DrLaRosa.blogspot.com. And I'll put the link up on my website if people want to check that out. Dr. LaRosa, You write that for patients with severe babesiosis, I give triple therapy with clindamycin, azithromycin, atovaquone, as clindamycin has the most rapid killing based on time kill curves. Can you lay that out for the layperson?
Sure. So for those who aren't aware, so babesiosis is an infection caused by an organism called Babesia microti. And it's a tick-borne illness. It's, in fact, carried by the same Ixodes tick that carries Lyme disease in the same areas. And it essentially causes what I like to call it or describe it to people as American malaria. The way it causes disease is it actually parasitizes, gets into the red blood cells, and causes them to lyse or hemolyze. And so you get this severe hemolytic anemia where you drop your blood counts, and that can cause downstream effects, including respiratory failure, renal kidney failure, and as well as liver impairment. So it's a severe disease, and it can be really especially severe if you're elderly or you're immunocompromised, and particularly if you don't have a spleen, either due to having had it surgically removed for malignancy in the past or having had a trauma and having had a spleen. It can be a life-threatening infection. In fact, there was just an unfortunate case published today about a patient in Connecticut that died. So it's not a trivial infection. Lyme disease gets a lot more publicity, but I've taken care of in my area. I'm practicing outside the Cape Ann area in Massachusetts, where we're in an endemic area, and some of the sickest people I see over the summer with babesiosis. Mm-hmm. So it's very important when treating this infection to one, identify it, and then to hit hard with agents effective against the organism. And it's usually you need more than one agent. And you mentioned atovaquone and azithromycin, which is the standard regimen. But if you look at studies that have been done, and some of them are older studies, the most rapid killing of the organism, in fact, occurs with an agent, clindamycin. And so typically in one of these severe hospitalized patients, what I tend to do is give clindamycin intravenously in addition to atovaquone and azithromycin, and then I'll follow the amount of parasites that are in the blood cells as well as parameters of how quickly their red blood cells are being destroyed. And once they improve, I'll back off and remove the clindamycin. But I think it's clindamycin is an essential part of the treatment for people with severe disease.
Now, getting away from your blog for a moment, but sticking with the babesiosis, in your part of the country, are you seeing any significant amounts of transfusion transmitted babesiosis?
It's a great question. So, a lot of people, particularly young people, will be asymptomatically infected. So it is not uncommon for somebody who believes themselves to be in good health to donate blood. So it certainly is an organism that gets into the blood supply. And in fact, when I practiced in Providence, Rhode Island, we saw a number of cases of transfusion-associated babesiosis, some quite severe. And actually, fortunately, through the blood bank, we lobbied, and now, at least in Rhode Island, all the blood that is screened for babesiosis. I'm not aware that that's being done in Massachusetts, but yeah, so it certainly is a concern to somebody who's receiving a blood transfusion in an endemic area.
Well, sticking with tick-borne diseases, you write in the blog, a patient is unlikely to have human granulocytic anaplasmosis with normal transaminases. Okay, that's a whole bunch of big words here. What's the disease we're talking about, and what's the laboratory test that you're talking about?
Right. So human granulocytic anaplasmosis, or HGA, used to be all called, used to fall under the name ehrlichiosis, but it turns out there's more than one disease, and not to get too far into it, but ehrlichiosis tends to occur in the south central part of the U.S., where human granulocytic anaplasmosis occurs in the northeast. And it's caused by an organism called Anaplasma phagocytophilum. And it parasitizes, it's a bacteria, but it parasitizes typically the neutrophils. You can actually sometimes see it on a stain. You can see it in the neutrophils on a stain. Not often, but sometimes it's there. But it is a systemic illness. It too is caused by the same tick that causes Lyme disease and babesiosis. So you, in fact, can see one of these three infections. You can see 2 out of 3. You can see all 3 in the same person, and they can occur in different combinations. And so, again, Lyme disease gets the press, but some of the sickest people, again, I've seen have human granulocytic anaplasmosis. And it's a systemic illness. These people get quite ill with a severe flu-like illness. It often is presents, at least to infectious disease physicians, as they're called upon for fever of unknown origin, because there's really no distinct, the symptoms are somewhat protean. They can be all over the place, but these people are profoundly ill with fever. They're often coughing because there's pulmonary involvement. But the key lab clues are they typically have a low white blood cell count, or what's called leukopenia. They'll have a low platelet count, the thrombocytopenia. They'll have some abnormal white cells, monocytes, and atypical lymphocytes. And they also get involvement of their liver, and it's usually their transaminases, so their liver enzymes, their AST and ALT. Again, it looks like a mononucleosis illness, but it's virtually unheard of to see somebody with anaplasmosis who doesn't have a blip in their liver enzymes. And the best way to diagnose it is with a PCR of the blood, which most labs can do. And the other interesting thing, and why it's such for an ID physician, it's gratifying, is it's incredibly responds well to doxycycline. In fact, it's remarkable that within 48 hours the fevers usually abate and the patient is feeling not all completely better, but significantly better. So it's important to pick up on the lab clues and to get doxycycline. And doxycycline, I often say, is somewhat of like a diagnostic test in this illness, that if they respond quickly and you have a suspicion, then it most likely is anaplasmosis. Okay.
Let me go over one more question. I got about 40 seconds, so let's see if you can answer it that quickly. You write a patient is unlikely to have babesiosis with a normal LDH.
Yeah. So this just gets back to what I was saying about babesiosis before, where it's a hemolytic disease. It causes the red blood cells to lyse, and one of the blood markers for hemolysis is the lactate dehydrogenase, the LDH. So if the LDH is not elevated and the bilirubin, indirect bilirubin, is not elevated, then it's unlikely the patient's hemolyzing, so it's unlikely they have babesiosis.
Okay, great. Well, Dr. LaRosa, I'm getting close to the break. Hopefully you can stay and answer some more questions about some infectious disease topics.
Sure.
Okay, great. And I want to encourage the audience to check out the website, outbreaknewstoday.com, outbreaknewstoday.com. Moments ago, I just posted, there was a bird flu strain that was circulating in some parts of the Philippines, and an Australian lab has identified it as avian influenza H5N6. So that's hot off the presses. And we see some stuff going on in the Americas, something called diphtheria, which is popping up pretty strong in Venezuela and Haiti. So check that out. Okay, and after the break, I'm going to talk more with Dr. Stephen LaRosa. I'll see you then.
Welcome back to Outbreak News This Week, your source for all the news about worms and germs. Here's your host, microbiologist and editor of OutbreakNewsToday.com, Robert Harriman.
Well, welcome back to the program. We're looking at a wide variety of infectious disease topics, and my guest today is Stephen LaRosa, MD. He's an infectious disease physician up in Massachusetts, and he's got a blog that has some pretty interesting stuff on it. It's called My Thoughts on the Future of Infectious Disease in Medicine, and that's at drlarosa.blogspot.com. I encourage you to check it out, and I will post it later on the website. Dr. LaRosa, another post that I saw, I read them all, but another one I found very interesting was concerning penicillin allergies. And in there, you note that you believe that these perceived allergies are not what they seem. Can you talk about what you mean?
Yeah, sure. So, wearing my hat as somebody who's actively involved in antibiotic stewardship, what you really try to do in stewardship is to make sure that a patient receives the right drug for their infection for the right duration. And often the right drug is a very narrowly focused drug, including a penicillin agent. But unfortunately, 10% of patients will say they have a penicillin allergy. And when you actually go through the data, it turns out that only 10% of these 10% are real. So really only 1% of the overall population has what would be called a true penicillin allergy. And by that I mean hives, anaphylaxis, throat closing, things that would be absolute contraindications. It's only 1%, but you have a large number of patients who will claim to have a penicillin allergy. And there's a few things that I don't think that we do, generally speaking, a good enough job at really drilling down to those true allergies, because we know from good data that if an allergy was remote, meaning more than a decade, and the patient doesn't really even remember what the reaction was, that it's unlikely that it is a significant penicillin allergy, and it would really be unfortunate to withhold a penicillin agent or a member of the penicillin family in that setting. Similarly, if someone gave you a history that they did in fact get a rash, but it was many days into therapy, then that's not likely to be an immediate hypersensitivity reaction, and that also would not be a contraindication to giving them a member of the penicillin family or beta-lactam family in the future. So I think we have to do a much better job. The other at drilling down in these histories, the other thing we know that in terms of cross-reactivity, there's another group of agents called cephalosporins that actually have a very low cross-reactivity with people who have true penicillin allergies, and that it's usually safe to use a third or fourth generation cephalosporin in those settings. I think this is all very important going forward. From when we're not using penicillin agents, the cost of therapy is going up. We have a problem with Clostridial difficile colitis cases, which we know tend to occur more often when you're forced to use some broad-spectrum non-penicillin agent instead of penicillin. And there are also reactions and toxicities to these other classes of drugs. So I think as part of stewardship, we need to focus more on what are really true penicillin allergies.
Well, let me try to personalize this a little bit. When my daughter was very young, she had hives, and it was attributed to penicillin. And here she is now in her mid-20s. She just had a baby, and the concern about Group B strep and all that, and
Sure.
and I asked her, well, what did they say to you if you were colonized? And they said, well, they would have to give me something else. I think it was cefazolin. And
Right.
but my question is, here she is in her mid-20s. How can she truly rule out a penicillin allergy?
Right. So if the facility has, a hospital has the wherewithal, you can do skin testing, which is very reliable. If it's on an elective basis, actually an allergy and immunologist can do skin testing to test for penicillin allergies. The other thing is you can, if you're on an elective basis, you could go to an allergy immunologist and get that done. But the other thing to remember is that if penicillin or one of its close relatives is truly the drug of choice, there are desensitization regimens that can be performed within the hospital where you get increasing doses under close supervision of the agent that you're allergic to, and it can desensitize you such that you would be able to undergo the drug that you need. So this comes into play. We see this often with, for instance, syphilis, where penicillin is still the drug of choice. We desensitize people. With the MSSA infections that I was talking before, we'll desensitize people so that they can get a beta-lactam drug because we know it's superior to vancomycin. So there's that regimen. In the setting, which is not the setting of your daughter, but people whose reaction is really, they can't remember and it was remote, if they're under close supervision, we'll give them the drug in the hospital under close supervision, knowing that it's quite unlikely that they probably will not have a significant reaction.
Interesting. Now, one more blog post that I want to discuss before I let you go is about Lyme disease treatment. And Lyme disease is a topic that comes on my website quite a bit. I have a lot of people that bombard me with emails about Lyme disease. So, and in your blog, you write about some soul searching that you did concerning Lyme treatment. Can you tell us what you came up with?
Sure. So, as somebody who practices in a Lyme endemic area, would get called on and asked questions about treatment. And as your show has said, there's varying. It's a quite contentious area in terms of physicians who practice according to the IDSA, Infectious Disease Society of America guidelines, versus the ILADs or Lyme literate doctors. And a lot of it gets around duration of therapy. And unfortunately, I practice according to IDSA guidelines, which is usually a short course of therapy of 10 days to 14 days for an erythema migrans or early infection, and a month for Lyme arthritis, up to a month for CNS infection. But I don't practice or am not according to what the Lyme literate doctors often will do in terms of prolonged therapy, because what we don't have as yet is definitive data that there is truly a persistent infection that requires prolonged therapy. In fact, the trials that have been done of prolonged therapy antibiotic therapy have not shown an improved benefit. And giving somebody prolonged antibiotics is not without its side effects. So, but the soul searching is, I wanted to dig down into the literature to see if there's something that I, should be thinking about, anything that's changed. The last Lyme IDSA guidelines, I believe, were published in 2006, and probably because of political reasons, it still hasn't, a revision still hasn't come out. But there are some things that I found, which is there is a school of thought that, at least in vitro, there's some data that maybe there's some other forms of Lyme disease outside the spirochetal form, so-called round forms or cystic forms and biofilms, and that these, at least in vitro forms, may not respond to the antibiotics that we typically use, like doxycycline or ceftriaxone or ceftriaxone, and that in fact they may respond better to agents such as daptomycin, which is an available IV antibiotic, or tinidazole. And it really got me thinking that what really needs to be done is probably more trials, that we're not done with clinical trials in Lyme disease. And if one is going to look to see if there's a potential that treating persistent forms makes a difference, that maybe the testing should be done with some of these agents that have activity against these other forms. So an initial maybe duration of therapy with doxycycline and ceftriaxone, followed by one of these antibiotics that kill the persistent form. So I think there needs to be more work there. The other thing is that undoubtedly there are people who continue to suffer after they're treated, and a lot of people believe this is probably immune related. And there's some fascinating data that maybe it's not that there are actually live organisms present, but that the DNA from these organisms is still persistent, and that's what's triggering immune phenomena. And there's some data out of Texas Tech that if you gave an antimicrobial peptide that binds Borrelia burgdorferi DNA and causes macrophages to engulf it, that you might have an improved outcome and you might limit these immune phenomena. So again, maybe we're just not doing the right clinical trials or haven't done all the clinical trials that we need to help these patients. And then the last thing is along the lines of diagnosis. We currently use a two-tiered diagnosis of an ELISA followed by Western blot, and sometimes these they lack sensitivity, and it's hard to tell the difference between old infection or somebody who's had a remote infection and a new infection. And there's some fascinating data that we actually can look at somebody's metabolomics, meaning the proteins that are released in their bloodstream, and that there's data that you can actually use a metabolomic signature of proteins that are released in the blood that can actually distinguish early Lyme disease. So I think we have work to do on the diagnostic side in clinical trials. So I guess the soul searching just resulted in the fact that we're not done yet, that there's still lots of questions that have to be answered.
No, that's a good way to put it. And I know in your article that you mentioned the use of stevia, and I've had Dr. Eva Sappy. She's been doing a lot of research on that on the show before. And you see any promise with that?
Well, it's stevia is obviously it's used as a nutritional artificial sweetener, but you're right. There's data about it having effects in vitro against these biofilm and round forms. Certainly is a compound that's generally regarded as safe, and so there's no reason that this couldn't be incorporated into a clinical trial to see if it has added benefits on outcome. I don't think it would necessarily supplant current therapy, but would be an additional adjunct. But in the setting of a clinical trial, I think we do have to be data-driven and evidence-based driven here. Unfortunately, in Lyme, there's a lot going on that's not necessarily evidence-based.
Yeah. Now, you did say that obviously you're in Massachusetts, so you are treating Lyme patients in your practice, and you said that you go by the IDSA guidelines. How successful is the treatment of these patients based on the IDSA guidelines? Yeah,
so we see a lot of what I'd like to say. The patients I see fall into a number of different groups. One is a lot of the people I see come with a clear, objective manifestation of Lyme disease. They have a Bell's palsy. They have an erythema migrans rash. They have heart blocks. from cardiac involvement, and they have Lyme arthritis. And those people with a focal finding, that group, they tend to respond, I think, quite, and also Lyme meningitis. You see a fair amount of Lyme meningitis as well, with or without Bell's palsy. And those people, I think, respond quite well to the regimens according to the IDSA guidelines. And then there's the second group with people with a number of vague, let's say, symptoms, and who have been told that they have Lyme disease, and they've had a number of weeks and months of antibiotic treatment, and really are not feeling any better. And that's, if you read the literature, that's about 10% of people. I'm not convinced that they have persistent infection. I don't think there's data yet to support that. In vivo, in vitro, possibly, but not in vivo. And they've not gotten better despite recurrent courses of therapy. And that's a tough group because I believe that they're actually having symptoms.
Sure.
Though many of those may be immune, and again, maybe they'll be in the future adaptable to other therapies. Those tend to be the main groups that I see.
Yeah, it's definitely a tough topic. I hear it from both sides pretty frequently.
Yes.
All right. Well, a very interesting discussion. I appreciate it. The website, again, is My Thoughts on the Future of Infectious Disease in Medicine. That can be found at drlarosa.blogspot.com. And I'll put the link up on the website. And I want to thank you, Dr. Stephen LaRosa, for your time and expertise. I appreciate it.
My pleasure. Thanks for the time.
Okay. All right. That was a pretty good discussion. I hope you all enjoyed that. And I want to try to get something in pretty quickly. We haven't heard a lot about Zika virus this year. There's been some news, but not a whole lot, not like compared to the last couple of years. So I wanted to play a little segment out of my discussion with Dr. Michael Osterholm up at CIDRAP. And basically, why are we not seeing a lot of Zika right now? So let's go ahead and take a listen to that. Now, you know the numbers, and it appears Zika has all but disappeared in the Americas. So what's going on? What is the story behind the story?
Well, first of all, Zika hasn't disappeared. Clearly, there are cases occurring throughout the Americas, including still some cases here being seen in the United States that are related to exposure actually here in the United States, particularly in Texas. But the case numbers are way, way down from several years ago. And this is actually not unexpected. If one looks at a companion virus, chikungunya, which also is being transmitted via the same mosquitoes, Aedes aegypti and potentially Aedes albopictus, we actually see a very similar kind of from year-to-year variation pattern. Unlike the other main virus transmitted by Aedes aegypti, namely that of dengue, which actually has multiple serotypes, so that you can actually have multiple dengue infections, meaning that immunity is not across all the strains. So there you can see more ongoing activity from year to year. But when you have these single virus strain kinds of issues like chikungunya or Zika, what we typically have seen in the past is accelerated activity for a period of time, anywhere from 12 to 24 months, and then a relative quiet period, meaning that transmission is decreased, but only to come back again. This happened with chikungunya in Asia, where we saw, for example, in the 1960s and 70s, substantial activity. It then went into a 10-year period of low sporadic transmission. But then again in the 1990s, as the virus was at one point really considered hard to find, then suddenly it came back. And then in 2005, there was another round of large epidemics in Asia. India reported more than 3 million cases of chikungunya in 2006. And so we can expect to see the same thing with Zika and chikungunya. For example, chikungunya, which caused a substantial number, thousands and thousands of cases of illness in Brazil back in 2008, and 14, 15, it was thought at that time that, in fact, it was a situation where it had gone away. Yet now this year we've seen substantial transmission occurring there with well over 120,000 cases. So expect the same with Zika. We're going to see Zika come back next year or the year after, and it will come back with a substantial head of steam.
Excellent. So if you want to check out the rest of that interview with Dr. Osterholm, you can check it out on the website, outbreaknewstoday.com, or iTunes, or on Stitcher Radio under the title Outbreak News Interviews. So I encourage you to check that out, and I encourage you to check out our series that we'll be doing on the story behind the story. He's a great guy and a very knowledgeable man. Let's get a little news in there before we close up shop today. And reports from my friends up at CIDRAP, up at the University of Minnesota. There was a couple studies that were done recently concerning Zika, and one was in the Lancet Infectious Diseases, and it said that, men who contract Zika virus have lower sperm counts for about 1 to 2 months after infection. And the study followed 15 French male volunteers who provided semen samples for 4 months following a Zika virus diagnosis. And on average, the men's sperm counts plummeted from 119 million spermatozoa on day 7 post-infection to 45.2 million by day 30. Now, by day 60, the average sperm count rose to about 70 million, and by day 120, it was back to normal. So pretty interesting stuff, but it just shows that, here's some more insight on how Zika can affect the male reproductive health. Some scientists that worked on the study out of Italy said, quote, "These findings suggest a direct effect of viral infection on the testes or epididymis with impairment of sperm development, in agreement with findings in animal models." And they also report on the saliva test. There was a study done in the Journal of Dental Research that says that testing peptides in saliva may be a quick way to diagnose the Zika virus. And the research is based on the saliva of a woman who contracted Zika while pregnant with twins. One baby had microcephaly, the other did not. And the researchers were able to pinpoint specific proteins in her saliva that confirmed infection with Zika. And now the current blood tests for Zika that detect the RNA will detect it only about 5 to 7 days after infection. But the saliva peptides can be tested for up to 9 months after infection, which would make it really useful for monitoring patients who are exposed to the virus but are asymptomatic. So I encourage you to check out their website. It's a very good website. It's called cidrap.umn.edu, and the writers up there do a fantastic job of reporting on infectious diseases. Doing a little news scan before we hang it up for the day. Candida auris. This is a very drug-resistant yeast. The number of cases in the U.S. has risen to 112, according to the latest update from the CDC. And out of the 112, 100 of them, the vast majority, have been reported in New York and New Jersey. And then there's a sporadic cases in several other states. So keeping an eye on this. This is a serious issue concerning, particularly in hospitals, and there's a lot of drug resistance. All the major classes of antifungals, it shows quite a bit of drug resistance. So, and the fear, of course, is the capability of spreading from patient to patient. So keep an eye on that. You can check out more on that story at outbreaknewstoday.com. Okay, let's go ahead and get things wrapped up. I want to thank my guest, Dr. Stephen LaRosa, and I want to thank you for listening. And I will see you next week on Outbreak News This Week. Good night, and God bless.
Thank you for listening to Outbreak News This Week with Robert Harriman. If you missed any part of today's program, you can listen to the podcast anytime on our website, outbreaknewstoday.com. Make sure to join us here next week for Outbreak News This Week with Robert Harriman.